In this lesson, we'll concentrate on the etiology, prevalence, clinical appearance, and classification of epiretinal membranes. We will also have a slide or two on the histology. If you research the older literature, you will find many different names for this condition. They include the clinical descriptions of cellophane retinopathy, surface wrinkling retinopathy, pre-retinal fibrosis or gliosis, as well as the more recent macular pucker and epiretinal membrane descriptions. The vast majority of epiretinal membranes are idiopathic, and they're associated with the development of a posterior vitreous detachment. Autopsy studies show a presence of 50% if a PVD is present as well. This is much higher than in clinical studies, as often membranes are mild and do not cause vision problems and therefore are not diagnosed in the clinic. There are secondary causes other than the posterior vitreous detachment, and these are inflammation such as uveitis, trauma, surgeries, or tumors. Now, if you do a careful examination on your patients, you will find epiretinal membranes in about 2% of your patients who are over 50 and upwards of 20% of patients if they're over 70. There's no gender predilection, and it is often bilateral. And these figures do come from both the Beaver Dam Eye Study and the Blue Mountains Eye Study. And again, just to go over it again, there is an increased prevalence after uveitis, trauma, upwards of 3 to 8% after retinal detachments, and after retinal vein occlusions as well. If you look in some of the informed consents after lasering, whether for tears or for diabetic retinopathy, there is an increased incidence of epiretinal membrane formation as well. There is not one specific composition for the epiretinal membranes. The membranes may be acellular, composed of posterior cortical vitreous material, or it may have cells in the mix. These cells may be migrated RPE cells, glial cells, astrocytes, myofibroblasts, and also hyocytes. Here is a slide courtesy of the Jules Stein Eye Institute, Dr. Krieger and Dr. Foos. You can see the ILM, and that is marked lower. And then there's a glial cell, and you can see that growing through a break in the internal limiting membrane. And then you can see a cellular epiretinal membrane proliferating on the surface of the internal limiting membrane. Interestingly enough, you cannot always judge the symptoms and the vision based on how the epiretinal membrane looks. Many times, the diagnosis is coincidental on the exam, as 2/3 of the patients have vision of 20/30 or better, and they may have no blurring or distortion of their vision. About 5% of the time, the vision may be as worse as 2200, but most of the time it will be somewhere between 20/30 and 20/70. We'll now go on to the clinical appearances and classification of epiretinal membranes. The simple classification system is simply mild, moderate, and severe. The clinical appearance of a mild membrane could be just as a glinting reflex to the macula. There's no distinct edge to this membrane. You'll see a loss of the foveal reflex. Sometimes there may be just a little yellowing of the fovea or a more of a reddish, ruddy red look to the fovea. The OCT will have a loss of the foveal depression, but no interretinal edema, cysts, or any outer segment changes. What is interesting, however, many times when I see this, I think it's probably the ILM, and at surgery, the thickness of this membrane does not match what I think it should be clinically, and also with the symptoms that the patient is giving you. A lot of times there's not a direct correlation between the clinical appearance and the symptoms. First, just a really quick comment on the sheen that you see, and this is an asymptomatic 17-year-old, and this is just a plain old youthful sheen. You can see there's a good foveal reflex, that the vessels are not distorted, the vision is good. So usually this youthful sheen is lost in the 20s and 30s, but do not confuse yourself with this normal look. To be really honest, I think you would be hard-pressed to claim that you can really see a membrane on this patient on the clinical photograph. However, on close examination, you can see a slightly elongated reddish foveal reflex, and there's some really subtle striae in the superior retina. But is there a glinting reflex, a thick membrane? No, at least not that I can see. The OCT does show the epiretinal membrane and a mild amount of wrinkling of the surface, and there's some little hypo-reflective area between the membrane and the surface of the retina. That's usually seen on the OCT. We'll have 3 quick slides on this patient who is asymptomatic. You can see that the macula of the left eye is slightly whitish in appearance. There's no great foveal reflex. It's a little bit more yellow-red, a little bit larger than you would expect. And on the red-free photograph, there's not a great foveal reflex, but no membrane is really easily seen either. Here is the patient's fellow eye, the right eye. The blue arrows do point out a fairly good edge to the epiretinal membrane. The fovea also has just a subtle abnormal look to it. And if you look between 330, 4, 5, there's some extremely subtle striae, and you can see this both on the fundus photograph as well as on the red-free. And here's the OCT of that patient, both the right eye and the left eye. And as you can see, there's some subtly different appearances to the OCT. The membrane is seen easily in the left eye as a hyperreflective membrane and mild surface wrinkling. The white arrows of the OCT in the right eye point to the membrane, and then there's also a blue arrow pointing to an irregular surface, but you really don't see the membrane over that area of irregularity. In a slightly more severe presentation, or what we would call moderate macular pucker, you can have some macular distortion with some foveal ectopia and a pseudo-hole or a macular hole look. The retina itself may be a little bit edematous, and you can have some whitening of the retina. The retinal vessels can either be straightened or tortuous depending on the direction of the tractional forces. And occasionally there can be some cotton wool spots and hemorrhages, and also you can get some small telangiectatic vessels around the fovea. Here's a moderately severe epiretinal membrane. You can see the whitening of the retina and the membrane. There's some tortuosity of the vessels both superior, a little bit of dragging of the vessels inferiorly. You can see an edge to the membrane in the inferior mid-macula, and there's a pseudo-hole look to the fovea. Here's a very magnified look at an epiretinal membrane. You can see the glistening look to the central macula, and some of the vessels are obscured superiorly, and there's a slight tortuosity superior to the fovea and inferior, and the vessels are being dragged just subtly towards the fovea. This patient is post-cataract surgery. Vision didn't come back quite to what the patient wanted, and the vision is about 20/40. You can see the striae, not so much the membrane, but the striae, nasally, supranasally, and superior to the fovea. And again, the foveal reflex is not quite normal. It's a little bit more yellowish than the reddish look that you would like. This is a 55-year-old woman who's had blurred vision in the right eye for about 6 months. Her vision was recorded at 20/50. You can see the very distinct white epiretinal membrane in the macula, and especially on the infrared, you can see the retinal striae and some of the straightening of the retinal vessels. The OCT itself shows a very thick membrane, loss of the foveal depression, and some retinal thickening as well. To label something as a severe epiretinal membrane is just one of degree. There's more visual loss, larger hemorrhages, more retinal edema. Oftentimes, there will be intraretinal cysts and also outer segment involvement on the OCT. The OCT changes we will go into in more detail in another lesson. And with a severe epiretinal membrane, there's usually quite an amount of distortion, retinal edema, and much worse vision than on the milder membranes. Many times this will occur post a lot of inflammation and especially after retinal detachment surgery. The membranes can also cause tractional elevations of the retina, and at times it is called posterior PVR. This patient did have a severe membrane after retinal detachment surgery. Here's a patient with a severe epiretinal membrane. He's got obscuration of the central macula. He's got the whitening of the retina. There's some pretty good intraretinal hemorrhages. They are the flame-shaped hemorrhages. Don't confuse this with either a vein occlusion or a subretinal nevascular membrane giving this look. A subretinal net will give subretinal hemorrhaging. It won't give you these superficial hemorrhages. So make sure you understand where the pathology is and you won't get confused. Again, this patient had a prior detachment. This is more of a posterior PVR type of a look. There's so much distortion and traction on the capillaries. They're breaking down microscopically, leading to the hemorrhages. This patient had a vision of 2400, and he eventually underwent pars plana vitrectomy and membrane peeling. And here is this patient. The color photographs are from 3 years after the surgery. The vision was recorded at 20/60, and there was a mild cataract as well. He eventually underwent cataract surgery and a YAG laser. The OCT was from 5 years later, and you can see that there's just about a normal contour, although he does not have a wonderful foveal reflex. So in summary, epiretinal membranes are very prevalent, and especially in the older population. While the vast majority are asymptomatic, while I was in private practice, probably once or twice a week I was actually peeling membranes, and I do that much more commonly than actually doing a retinal detachment. The membranes are usually related to posterior vitreous detachments. They can be either cellular or acellular. And then the history-wise, most often they progress for 3-4 months, and then visually and symptomatically, they're very stable. Occasionally they can progress, but that is not the usual. There are variable clinical and OCT appearances. And in the next lesson, we'll go over in more detail some of the vitreoretinal anatomy, the adhesions, the OCT findings, and the relationship of that to surgery for this problem.